start my talk, I want to talk about a program that we actually inherited or adapted from Vancouver called Totally Outright. And it's for young gay, bi, queer men. And it's a leadership program. We sell it to the city as an HIV prevention program because, you know, building capacity within community is HIV prevention. And one of the important aspects of that program is actually teaching young gay guys about the history of queer organizing and HIV organizing. Because one of the things we want to actually do is create another generation of young gay, bi, queer guys who see HIV and understand the history of community organizing and see this as a health concern. And I know that Tim has come out to Totally Outright and presented on the work of AIDS Action Now. And I've heard from graduates who had no idea about HIV organizing. They always just assumed that organizations were there, or they never thought about organizations. And so I think these kinds of gatherings in which we can actually talk about where we came from and how we've changed are important. So now I'll get to my written part. And I don't have a PowerPoint because I'm resisting the professionalization of HIV. So, austerity and integration. While these might seem like new concepts in our work, I'd actually argue that this has been something that AIDS organizations have been facing for many years. In fact, when it comes to the issue of austerity, something that we faced from the beginning of funding for community-based organizations. You know, as you heard this morning, most of us began as voluntary organizations. All of us began as voluntary organizations because of government and society's unwillingness to deal with a disease that was seen as affecting others in the 1980s, predominantly but not exclusively gay men. And it was only through in-your-face advocacy did government funding appear. But it's never been adequate. Merely enough to allow HIV organizations to get set up and to function, albeit at an inadequate level, and constantly work in an environment, as Maureen said, of low wages, inadequate resources to make a true impact on HIV prevention, and inadequate resources to support those living with HIV. In other words, from the beginning and to today, we've always just been making do. You know, we saw austerity further impact Ontario HIV organizations in the 1990s during the Mike Harris conservative government years, which resulted in a slashing of social benefits, the implementation of workfare, and a suggestion from the then Minister of Community and Social Services that social assistance recipients who had had their benefits reduced should consider haggling down the price of dented cans of tuna to 69 cents each, and I am not making this up. He also claimed that single mothers on social assistance had ample time to find jobs after having been given 3 months warning of a 22% cut in benefits. Austerity and the need for AIDS organizations to begin to more deliberately address issues related to poverty, housing, and income security for people living with HIV is not new. And as a sector, we've increasingly and incrementally taken on more and more complex work within a context of static underfunding. In many cases, we took on this work because nobody else would do it. Other sectors being reluctant to better understand the unique needs faced by those living with an increased risk for HIV because of HIV-related stigma. But is this sustainable, particularly in a climate of increased austerity? Can we, as HIV organizations, and more importantly, should we, be taking on the work of, continuing to take on the work of other sectors? Or are there other approaches that we need to take? Here in Ontario, at least, we've had dedicated provincial HIV/AIDS funding, which is not the case in many other provinces here in Canada. And here in Toronto, we have had a city government that has supported funding for HIV prevention and harm reduction programming. At ACT, as an example, our federal funding for HIV-related work actually reflects the smallest proportion of government funding. But even with robust support for HIV prevention, care, treatment, and support programs through the province and through the AIDS Bureau, and HIV and harm reduction funding through the city, we can't assume that this will always be there. Provincial funding has been flatlined for years. We can't assume that the forces pushing integration will mean that dedicated HIV-related funding will exist in either Ontario or Toronto in the future. And to Maureen's point, I'm going to talk about the merger of formerly separate HIV prevention and harm reduction grant streams into a new fund titled the Toronto Urban Health Fund, and I note the lack of the words either HIV or harm reduction in that, has not been without huge problems. A new application and review process meant that organizations that had been receiving funding for years for either HIV prevention or harm reduction work did not have their past history taken into consideration. And the inclusion of a stream within that fund focusing on child and youth resilience, which is intended, for all good reasons, to build capacity for young people so as to further reduce HIV risk or problematic substance use, failed to explicitly mention gay youth as a priority, despite the fact that gay and bisexual men continue to comprise the overwhelming majority of HIV new diagnoses in the city. And in 2012, the most recent data for the city, gay men and bisexual men and other men who have sex with men comprised 65% of all new HIV diagnoses, with the highest rates of new diagnoses among aged 30 to 34, followed closely by those aged 25 to 29. Yet, no inclusion of that in child and youth resilience. That we have faced and continue to face austerity is a reality of working in a disease that does not affect a broad base of society, but continues to affect those that are seen to be outside of the mainstream. So what do we do? While the trend has always been to take on more, we've had to recently look critically at what we are able to do and have to actually look at and focus our programs on areas where we have the most expertise and where we can show we can make the most impact, and make often difficult decisions to end or wind down programs that are either not adequately funded or cannot really have an impact because they are not adequately funded. This has been done intentionally, and we've had to look at service providers outside of the HIV sector, who I argue should be taking on this work in order for us to be able to have a comprehensive response. And as people living with HIV live longer, it becomes our role to ensure that other organizations and systems adapt and change in order to provide culturally competent programming for those living with it and those at risk for HIV. Integration, again, not necessarily a new concept, and something that we in the HIV sector have been taking on incrementally for years. With a move to integration of HIV, hepatitis C, and other sexually transmitted and bloodborne infections at the federal level, there are obviously concerns. Concerns, as Maureen stated, that opening up calls for funding outside of organizations that have historically focused on HIV or Hep C will mean that funding, which is not going to increase, by the way, despite calls to do so, will go to large community health organizations that are able to write really good funding proposals, even though they may not have any history working with populations. But that does not have to be the case, and as a sector, it's incumbent on us to use the evidence and to justify the need for our programs. As I said, integration is not new, especially when we talk about HIV transmission and sexually transmitted infections. We've been integrating sexual health into our work for years, and we've known that sexually transmitted infections increase one's risk for HIV, and for those living with HIV, for HIV transmission. So we've been quietly integrating broader sexual health messaging into our prevention work without more funding. US researcher Ron Stahl has written much about the topic of syndemics, or a series of epidemics that are faced by gay men which increase their vulnerability for HIV. Factors related to mental health, childhood bullying and trauma, homophobia, racism, substance use, and as a coping mechanism all contribute to HIV vulnerability for gay men. And this has meant that as HIV organizations, we've had to take that on. And we've been told by the powers, there's no more money for it, as though gay men's health doesn't matter. The key then is how we address this in the context of austerity. Do we merely become mental health and substance use experts as well, on top of being HIV prevention, sexual health promoters, case managers, supporters, you name it? Or do we use evidence, and the evidence exists, that broader health systems, including mental health, addictions, healthcare system, need to better address the needs of the communities that bear the burden of HIV? And how can this be made to happen in a health and social system, and health and social service system that's already overburdened, is either unwilling or unable to address the unique needs of the populations most at risk for living with HIV? And just as racism and sexism creates barriers to healthcare access, so does homophobia, and so does heterosexism in 2014 in Toronto. So it's incumbent on us as AIDS service organizations to start to make more meaningful connections, both inside and outside of our sector, in order to ensure the best possible health outcomes for those living with and those at increased risk for HIV. Because if we don't do it ourselves, it will be imposed on us. And it's also incumbent on us to use the language of integration and austerity, which calls for increased efficiencies, and the evidence that clearly shows that the social determinants of health have an impact on those living with and at risk for HIV, to direct policymakers within governments to facilitate a more holistic, integrated, and responsive health and social service response.